Without any further delays, let's get right into the abstracts. We have a wonderful abstract from Professor Priscilla Brastianos from Dana-Farber Cancer Institute. Her abstract is titled Phase 2 Trial of BRAF MEK Inhibition in Newly Diagnosed Papillary Craniopharyngiomas. The floor is yours.
Thank you so much for the opportunity to present at this fantastic webinar. It's quite an honor. I just want to make sure you can see my slides and the full slide deck?
Yes.
Perfect,
Yes.
Thank you. So on behalf of the Alliance team, I am delighted to present our phase 2 trial of BRAF MEK inhibition in newly diagnosed papillary craniopharyngiomas. These are my disclosures. So craniopharyngiomas are rare suprasellar tumors that occur in children and adults. And although typically histologically benign, they can cause significant impairment through compression of critical structures and morbidity of treatment. And they may have a cystic component that can dominate mass defect, as you can see here. And unfortunately, once surgery and radiation have failed, there's no effective medical treatment for this disease. And craniopharyngiomas could be subclassified into two subtypes, adamantinomatous and papillary. Adamantinomatous tend to occur preferentially in children, and papillaries tend to occur in adults. And to date, these two subtypes were managed in a similar way with surgery and with radiation. And in work we published a few years ago, we found that both subtypes are characterized by single driver events. So we showed that 95% of adamantinomatous craniopharyngiomas had activating beta-catenin mutations, and 95% of papillary tumors had activating BRAF V600E mutations. Based on this data, we then designed a multi-center phase 2 study in patients with papillary craniopharyngiomas. And this was an alliance-led study. And there were two cohorts, cohort A, newly diagnosed craniopharyngoma, and cohort B, patients with recurrent papillary craniopharyngoma after radiation. As part of this study, patients receive 4 to 5 cycles of vemurafenib, cobimetinib, followed by standard surgery or radiation, or in the case of cohort B, continuation of vemurafenib, cobimetinib as per the discretion of the treating physician. A cycle was defined as 28 days of treatment, and the primary endpoint was imaging response by central review. And both enhancing the cystic volumes were included in the response measurement. And we used a Simon two-stage design comparing a null response rate of 5% against an alternative of 30%. And as part of the study, we would do an interim analysis at 9 patients. If there was at least one response, then we would continue enrollment. And the final analysis would consist of a total of 16 patients. And if at least three or more total responses were seen among a total of 16 patients, treatment would be worthy of further study. We've now completed accrual to the newly diagnosed cohort, cohort A, so that will be the focus of this talk. So key inclusion criteria included biopsy-proven papillary craniopharyngioma. We did central pathology review with IHC confirmation of BRAF, measurable disease. And for cohort A, no prior therapy received other than surgery. And cohort B, as I mentioned, progressive disease after radiation. And here are the patient characteristics. Median age, 49.5, 15 patients with an ECOG performance status of 0 or 1. And the median baseline tumor volume was 2.75 centimeters cubed. The median number of treatment cycles with at least one agent was 8. And of note, patients were allowed to stay beyond 5 cycles of MCOBI if they were benefiting from therapy and tolerating treatment well, and with approval from the study chairs. Given the excellent tolerance of the drugs and the continued response on imaging, many patients did go beyond the 4 cycles. 16 patients are now off treatment, and treatment after vemurafenib cobimetinib included 1 patient received surgery, 8 patients underwent radiation therapy, 2 patients went on to systemic treatment off protocol, and 7 patients received no treatment after vemurafenib cobimetinib. All patients who completed 1 or more cycles of therapy responded to BRAF MEK inhibition. We had 1 non-responder who had only received 8 days of treatment before stopping therapy due to toxicity. Thus, the study met primary endpoint of overall response rate. And we observed dramatic tumor responses. So here I show you the maximum percent volumetric change from baseline to nadir while on BRAF MEK inhibitor therapy before starting any other therapy. The median tumor reduction across patients was 91%, with a range of 68% to 99%. And again, that patient highlighted in yellow who did not respond had only received 8 days of treatment. And here I show you an example of a significant response of a patient after just 8 weeks of treatment. So this is pre-treatment and this is week 8. And similarly, here's another example. So pre-treatment scans, then at week 8, and continued response at week 16. And here I show you progression-free and overall survival. 12-month progression-free survival was 87%, and 12-month overall survival was 100%. And here I show you the toxicity. Grade 3 adverse events in 2 or more patients included rash, increase in alkaline phosphatase, ECG QTC prolongation, and there was 1 asymptomatic grade 4 CPK increase and 1 asymptomatic grade 4 hyperglycemia. In conclusion, vemurafenib cobimetinib resulted in a significant response in all patients who received 1 or more cycles of therapy with a median 91% volumetric reduction with modest toxicity. And BRAF MEK inhibitors could be a powerful tool in the treatment of previously untreated papillary craniopharyngiomas, with the potential to avoid the morbidity associated with radiation and with surgery. And I would like to thank our amazing team for contributing to these efforts, especially Dr. Eva Galanis, Dr. Fred Barker, Priya Kamthekar, Sandra Sanagata, our imaging co-chairs, Elizabeth Gerstner, Timothy Kaufman, our radiation oncology co-chairs, Dr. Paul Brown and Dr. Helen Shee, and of course, all the investigators who have supported the trial and patients for participating. We learned a lot along the way with running trials for patients with rare malignancies, and it truly was a testament to the multidisciplinary and multi-institutional effort of the team. So thank you very much.